In this video, we discuss the use of amifostine during cancer treatment. As always, these ideas are discussed in more depth in the book Cancer Self-Defense 101, Quick Tips to Help You Survive. All citations for studies quoted in this video can be found in the book's bibliography at cancerselfdefense101.com. This video is intended as information, not medical advice. It is not intended to treat, diagnose, or cure any disease. Any medical advice should come from an appropriately credentialed medical professional familiar with your unique circumstances. There is a pharmaceutical antioxidant, Amifostine, that has been FDA approved for reducing radiation side effects. It has been through phase 3 trials and has been shown to decrease side effects without harming survival outcomes. In fact, if anything, it has a positive effect on tumor responses. In the late 1950s, the US Army began looking for radioprotective drugs in case of a nuclear war with Russia. Of the over 4,400 compounds they tested, amifostine offered the best radiation protection with the lowest toxicity. Amifostine protects healthy tissue more than cancer cells by a ratio of about 100 to 1. In 1979, amifostine had its first phase 1 trial to demonstrate its safety in humans. A full 9 years later, the first randomized controlled trial of amifostine was published from a group in Japan. This trial suggested a clinical benefit and reduced normal tissue damage in head and neck, abdominal, and pelvic tumors. Another randomized controlled trial out of the US a few years later demonstrated that amifostine protected healthy cells without decreasing the efficacy of chemotherapy in rectal cancer. In 1996, amifostine received FDA approval in humans for use to reduce the cumulative renal toxicity associated with repeated administration of cisplatin, a chemotherapy in patients with advanced ovarian cancer. In 1999, the FDA approved amifostine to reduce the toxicity associated with radiotherapy. This was based on a phase 3 trial in 315 head and neck cancer patients that showed amifostine led to a significant reduction in both acute and late toxicity without a reduction in locoregional control, disease-free survival, or overall survival. To this day, amifostine remains the first and only radiation protector that is FDA approved for clinical use. It has also been shown to reduce side effects in thyroid cancer, prostate cancer, cervical cancer, breast cancer, liver cancer, and more. A meta-analysis of amifostine use in lung cancer paired with thoracic radiation conferred a 62% odds reduction in developing esophagitis and an 85% odds reduction in developing pneumonitis. Another meta-analysis of 7 randomized controlled trials in lung cancer found that amifostine concurrent with radiation produced a 7% greater chance of having a response to treatment than radiation alone. Around 2000, newer methods of administering radiation, such as intensity-modulated radiotherapy, IMRT, came into use. IMRT, a precursor of stereotactic radiation, is able to adjust the intensity of radiation so that cancer tissues are targeted more than non-cancerous tissues. The reduction in side effects conferred by both IMRT and stereotactic radiation has contributed to a decrease in interest in amifostine. Incredibly, even though there are over 260 clinical trials studying amifostine, not a single one is a randomized clinical trial combining it with either IMRT or stereotactic radiation. As a sign of declining interest, only 24 clinical trials in amifostine have been performed between 2010 to 2022, less than 1/10 of the total output. As one review puts it, the use of amifostine in the IMRT era has been poorly explored and is worthy of future study. The seriousness of radiation side effects are so great that they need to be included in discussions regarding survival outcomes. For instance, amongst people who survived at least 3 years from a diagnosis of head and neck cancer, a type of cancer that receives a lot of radiation, secondary effects of radiation, such as secondary cancers and cardiovascular issues, including strokes, killed 44% of all survivors, whereas the primary cancer itself killed only 29%. Although amifostine is not commonly used, it may be to your benefit to discuss it with your oncologist. For more information about amifostine, please see the book Cancer Self-Defense 101 – Quick Tips to Help You Survive.